Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. It's Friday, March 2nd. This week, what is the future of hospitals? Epic's new Sonnet EHR and what it means for interoperability. And we dive deep on the role of technology in physician burnout. This podcast is brought to you by Health Lyrics, a leader in digital transformation in healthcare. This is episode number 8. My name is Bill Russell, recovering healthcare CIO, writer and consultant with the previously mentioned Health Lyrics. Today, I'm joined by a relatively new friend and first person to appear on 2 episodes of the show, Dr. David Bensema, former CIO of Baptist Health in Kentucky, who has started his second round of work in his, your pre-retirement phase of retirement. As we all know, you don't just go off into the sunset. People tend to pull you back into work. So, good morning, David, and welcome back to the show.
Good morning, Bill. Appreciate the chance to be here again.
Yeah, I'm looking forward to our conversation. A lot of good topics this morning. So this appearance is through a scheduling mistake on my end, and I appreciate you being so gracious to come back on the show. So normally we ask our guests, what are they working on? What are they excited about? I guess since you're the first returning guest, we'll modify it a little bit. What have you been working on since the last time we spoke, and what are you excited about these days?
Yeah, actually, you stimulated what I'm excited about at the moment. You wrote an article about budgeting and the need to plan to cut today for tomorrow, and it got me thinking about the process that we had put together. So I just submitted a piece to healthsystemcio.com on the daily discipline of budgeting, hoping that people can understand that budget cycles shouldn't be as traumatic as they've been in the past, and provide some insight from the 3.5 years of stumbling that I had, so hopefully some others can find a smoother path to their budgets.
Yeah, and there's an awful lot of talk going on right now around reducing the budget as more and more pressure comes on the hospitals from a budget standpoint. So did you just recently write an article for Health System CIO?
Just submitted the final draft yesterday.
Great. So can you give us like a preview of what you discuss in the article?
Yeah, part is that your managers have to have a regular cadence of looking at their human resource spend to be able to track whether on contracted or employed individuals, they're getting out of line. Either a positive variance, in which case you want to find out how can you perpetuate that positive variance, or the negative or harmful variance, where you've gone over budget, and catch it early so you can make course corrections and make sure you don't let something balloon, because the HR spend is our biggest. And then the other piece that I think is most relevant is in yours and my role, and in other CIOs and executives' role, set the example. And so we don't need the latest bright and shiny. You and I answer emails. We do some podcasts. We do some webinars, but we don't need the most powerful, lightest laptop in order to do our job. And I think showing that fiscal restraint is a good example for our teams.
Yeah, I agree. It's I used to have one of my vice presidents used to have the oldest iPhone he could possibly have, because he wanted to communicate to the organization that really the iPhone hasn't changed much since you get bigger screens and whatnot, but it really hasn't changed much in terms of its functionality. And he wanted to show them that essentially we're still doing the same things we were doing then. And he also he was sort of a no man left behind kind of thing. And he said, I will be the last person to get the newest iPhone. So once everyone in the organization has one, I'll move up. And I think people appreciated that. They appreciated the fiscal restraint and the fact that IT wasn't the one walking around with all the shiny new objects while the rest of the organization was stumbling along. So that was
Exactly.
Great move on his part. So okay, let's jump. A lot of news. So let's jump into the news. As first section, David and I have each selected a story to discuss, and I'll go ahead and kick us off. So, the future of hospitals is an article that appeared in the Wall Street Journal this past Monday in the healthcare section, which is a great section if you get that. I'm a former paper boy, so no matter what I do, I always have one paper delivered to the house so I can read a newspaper. It's just old habits die hard. But so we get the Wall Street Journal, great article. Let me give a recap real quick. The days, first couple of paragraphs. The days of the hospital as we know it may be numbered. In a shift away from their traditional inpatient facilities, healthcare providers are investing in outpatient clinics, same-day surgery centers, freestanding emergency rooms, and micro hospitals, which offer as few as 8 beds for overnight stays. They are setting up programs that monitor people 24/7 in their homes, and they are turning to digital technology to treat and keep tabs on patients remotely from high-tech hubs. They go on to talk about the economic drivers. There has been fewer admissions, fewer overnight stays, although the patients have gone up. And essentially what they're saying is there's just an awful lot of economic drivers. In one of the sections that's cut out from the story, they have some statistics of the total savings, inpatient versus outpatient. For instance, hysterectomy, there's a total savings about $4,000 per procedure, 480 out of pocket. They go on with cardiovascular, angioplasty, and they just have these numbers there, and they're pretty significant numbers. Having the procedure done in a traditional hospital gets to be pretty costly. So I'll summarize. Where do they think we're going? They believe hospitals are going to more helping patients at home, and they cite Mount Sinai's Hospital at Home program, which has saved Medicare $45 million. They're talking about building smaller facilities, and I have personal experience with this. We're doing, my company's doing some work for my hometown hospital system, and there's literally a street corner that has 3 buildings for St. Luke's University Health Network, and each of the buildings almost represents a different department that used to be in the hospital. You have, women's on one, orthopedic on another, oncology on the other. But they're smaller buildings, nice big parking lots, easy to navigate if you're going there. They're finding new uses for old hospitals. I thought the most interesting part of that was Geisinger's setup of a fresh food pharmacy that they're converting so that the community actually has a 50% predisposition towards diabetes, and they're recognizing the whole population health move that if we really want to get in front of this, it's better to help people with their food, and then help from afar. And we've talked about this before. HCA, Intermountain, and Mercy Health in St. Louis all have digital hospitals set up, and they're providing services to rural facilities. They're providing services to even some other large health systems where they are monitoring certain situations, and even some post-op and those kinds of things. So they're providing remote support and some expertise through that. So these are some of the things that they highlight in the story. So let's talk about this a little bit. I'll kick us off. So hospitals still absolutely will make up a significant portion of the revenue for health systems in the foreseeable future. There's no doubt about that. The big box hospital is going to be that. But what I want to talk about is what do we as CIOs and technologists do to prepare for this next wave of change, which is already really upon us. And as the phrase goes, and we talked about budget already, show me your checkbook and I'll tell you your priorities. The same is true in healthcare IT. Show me your budget and I can tell you an awful lot about what you value and what you're going to become in the future couple of years. If I were looking at health systems budget right now, there's a couple of things I'd look at and I'd ask, how much are you spending on things connected to the hospital versus new models of care? I see a lot of budgets very focused on the EHR. How many resources are you putting on the EHR, which is predominantly a system to run a hospital or to run a health network. And so much money is being still, even after the big EMR implementations, are still being focused on that. And not enough is being focused on the consumer. How much of the analytics budget is being spent on the consumer? How much of the budget is spent on the changing the way we experience healthcare? And those questions will lead you in the directions. You need to look within the health system. I believe you need to look within the health system and find some people that are doing some interesting consumer-based projects. And it may not always be in the traditional part of the organization, and begin to partner with those guys and look for new initiatives that are going to lead. And this is one of those areas that we lead as CIOs. We identify areas that have promise and utilize some of that margin budget that we have to support those and move them forward. So anyway, I thought it was an interesting article. David, um, I guess my question to you is, have you seen this transition away from hospital strategies in the health systems that you work with, and where do you think this is going to lead?
I think we've seen it to a large degree in the health system that I was with. We started in 2006 already looking to the ambulatory sites, decentralizing a lot of the care. Imaging centers moved off campus, infusion centers. So there was that, but they were still trying to do it on the hospital-based reimbursement model. Now with CMS declining to accept or to approve additional sites that are off campus in terms of hospital-based reimbursement, systems are having to figure out how to live on my old primary care budget. I'm an internist by training and practice, and we learned how to run things tight, and I think hospitals are starting to learn that. And so we're certainly seeing that. We're seeing a much more aggressive acquisition or alignment with home health to try to reduce the readmission rates, to try to move the care back into the homes. We saw a significant investment in the system that I was with right as I was leaving in telemedicine, both for visits, so communicating as you and I are right now, but also for telemonitoring, home blood pressure, home weights being fed back in to the home health. And I think the other thing that has helped is the investment in the EHRs in some systems, if they did a good cross-system integration, allow you to decentralize that care and do a better job of making sure that the patients are cared for where it's most appropriate for them. And then the final was the Ambulatory Surgery Centers Association. You saw systems that fought that a decade ago, and you saw systems that embraced it and partnered with their physicians. And now if you look at the systems that still have a margin, I bet they have some relationship with their independent physicians in an ambulatory surgery center and in other investments where they didn't fight the physicians, but they joined with them.
Yeah, I found it interesting, at least for our budget in the previous health system I was at. The medical group IT budget was really kind of paltry compared to the hospital, and there were many occasions where I sat down because we tightly partnered with them, but it was a separate budget. And there's many times where we had to sit down with them, and they said, "Well, we can't really afford that analytics package, or we can't afford that pop health package." And that partnership became really key because I first of all, I didn't understand that. And because of the way we did budgeting from the article you talked about, we always had some margin dollars to spend. And invariably it went to those guys. It was an opportunity to really bring those capabilities forward so that we can do a clinically integrated network better. We could do the ACO better. We could do analytics on that population. We could keep them out of the hospitals. And for some reason, I don't know if it's just history or whatever, that side has been starved and the hospital's been pretty well fed. And do you think that's going to continue to evolve and change, or do you think we're ever going to get to the other side of that? Because it really does take money away from the hospital when I know there's incentives, but it takes money away from the hospital when people don't come in for procedures and those kind of things.
Yeah, and I think we will see that shift over. I think in the system again that I left partially because when I was CIO, it was as we were transitioning to the integrated EHR, we were tearing out our existing systems, and so we did bring the physician enterprise under the same umbrella as the hospitals, and I was able to communicate to the system executives and to the board the need to think about them as a continuum. And I think as more and more people think about the care continuum and drop the walls of the hospital, at least figuratively, and think about how the patient moves through the system through care, systems will start to shift their budgets and understand that. I think it's still going to come down to, you've got to have, and I've seen a couple of articles now that say you need about 62% of your patients where you are at risk, where you are accepting, whether it's capitation or some form of full risk, in order to pay for these systems and to make that critical mass that tips you over to being able to successfully do that. Then you benefit from reducing your admissions. Right now, we're still trying to drive fee for service in most sectors of the markets, and that stops you or blocks you from shifting money away from the hospital.
And I think we see a good model of that in Sharp Healthcare down in San Diego. If people want to look into that one, they have a pretty high percentage of at-risk patients, and they are on a managed service contract. So that's pretty interesting. And you brought up, talking to the board and educating the board. That just reminds me of that's probably a good topic for a future episode of the role of the CIO in that. But let's kick to our second story, Epic. Well, actually, it's your story. I'll let you give it to us and give us a little recap.
Yeah, so I saw the article, and of course, we'd heard Judy announce last year that they were going to be introducing new EHR options, and Sonnet is going to be introduced at HIMSS. My take on the article is that it's kind of like Epic Light. In the article, they talk about smaller hospitals get it at a lower price, doesn't have all the functionality, doesn't have all the modules, but then they can add them later, which, obviously I'm an Epic fan. I installed Epic. I worked well with them. I think there's a lot of great things going on. But in this, I think there's that blind spot where Judy sometimes thinks that it's going to be world domination by Epic. And so this is declared as an advance of interoperability as they do the care everywhere more robustly for Epic users. But it doesn't say anything about how they're going to communicate with the others. And I know they're in the Sequoia project, and I think there's going to be advances out of that. But this article leaves people with that same sense that you've seen in the editorials and you've heard in some of the discussions, that Judy's not really playing with all the other players in the market. It's great if you're Epic, and I think she is moving to a comprehensive health record for patients in making the care everywhere more robust, having social determinants follow them wherever they are in the U.S., being able to communicate that. So if my snowbirds go down to Florida from Kentucky, they're going to get the same information shared in their Epic everywhere. That part's good. I think Sonnet getting into smaller hospitals is good. But I think I personally want to see the whole world moving much more aggressively towards interoperability. I think the ONC missed it originally. I think their idea that you could fix it after you allowed all these disparate EHRs to be built without it, we've got a mess. And I don't think Sonnet solves it, but I think it's a nice additional solution for Epic.
Yeah, this is one of those areas that it's being from the outside of healthcare 7 or 8 years ago. The first conference I went to, there was, I don't know, I guess there's 12 CIOs sitting around the table, and they asked us to all do our introductions, and they went around the table, and whoever the first person was, they gave their name, their system, their revenue for whatever reason, and what EHR they were on. And I thought, well, that's interesting. Okay, so it got to me, and I said, here's my name, my system, and both are impressive numbers, so the numbers are impressive. And then I said my EHR, and it was like I had said, I didn't really graduate from college. I only got an associate's degree, and I mean, you could see people look down their nose at me, and I was like, oh, this is fascinating. There's sort of a culture around what EHR you're on, and it sort of reminds me of the OS wars back in the day when people would take sides and say, I'm an OS2 guy, or I'm a Windows guy, or I'm a Novell guy, and it really doesn't help us at all, to be honest with you, to be so passionate about the EHR. My experience, and I've researched this pretty closely, is the net distinction between these EHRs is in terms of overall running a hospital and being efficient is not that distinct. In fact, we were a Meditech shop with 16 hospitals, $6 billion. And people would say, well, that's an awful system to run that kind of health system on. And I'll just tell you, from a number standpoint, it's highly efficient. It does lag in terms of the user experience, but overall, in terms of running the health system, it was effective. It had very good technology and modules. It didn't go down. It was a very stable system. And I find people get so passionate about this, and it's a little off topic. Let's talk interoperability on this. So the interoperability, I agree with you. I believe that Epic believes that the path to interoperability is if everyone gets on an Epic platform, then we will get to a longitudinal patient record. And that's just never going to happen, and we don't want it to happen. And we don't want it to happen for, I think the primary reason we don't want it to happen is because we saw the same thing in the ERP world. And when you get down to very few vendors and you get down to a certain market share for those vendors, the innovation slows down. And it's not because they don't have huge staff and huge budget. The innovation slows down because they have to innovate in a way that they're taking into account their European clients and their Australian clients and their 55 different clients in the US for large hospitals and their small hospitals. It just gets too complex to innovate. And so we actually slow down innovation. We slow down the market. So I'm not sure we ever want to get to a epic world domination anyway. So we should continue to look at things like the Sequoia Project and the Caring Alliance and some of the other initiatives that are out there as really the start of this interoperability journey. I sort of rambled there for a little bit. I'm curious what your thoughts are in terms of what's next on this and what's next on interoperability.
Yeah, well, the next on this is I think you're going to see Cerner and others work towards the comprehensive health record more and more. So the large players are going to be doing that. I agree with your assessment about the need for the competition to create innovation. You and I grew up with the big four, and we both drive better vehicles now because there's competition from overseas and from all around. So the innovation's there. I think the other thing on interoperability, I think the HITAC, I hold some hope that group is going to come to an understanding that interoperability is the must-have, and we have some legislation that's driving it. I think the physician voice, and you're going to get to that in a moment. The physician voice more and more is demanding interoperability. We're wasting too much of our clinicians' times, physicians, APRNs, PAs, nurses, looking for information that ought to just be there, and it ought to be in a usable format when it gets there, not in a linear format, the horrible CCDs that we saw the last several years. It's got to be better than that.
Yeah, I agree. And I'm looking forward to jumping to the next section talking about physician burnout. I mean, when I sat behind a physician at one point and just mirrored them for the day, I was shocked to find, they were jumping into all these essentially PDF files, and they, so they have 15 minutes with a patient, and think about it like you have this folder full of, 25 PDFs, and you're just rifling through them real quick. It really is an impossible job, which gets to, our role. So, in our Tech Talk leadership, we're going to talk a little bit about the role of IT and physician burnout. The reason I just appreciate your physician background, I'm going to use it here. So the ONC and CMS got an earful on EHRs. This was a Politico article, and I just read, ONC and CMS officials got an earful for a day-long listening session at Health and Human Services on Thursday about reducing provider burden from health IT. Speaker after speaker said physicians and nurses are on the edge of a nervous breakdown over the depressing hours they spend struggling with bad EHR workflows and government reporting requirements. So, let me ask you this. Let's start with the current state. Where do you think we're at with regard to physician burnout today, and what are you hearing out there?
Yeah, hearing a lot about it. The last AMA annual meeting, I'm a delegate for the state of Kentucky to the AMA. The last meeting was dominated by conversations regarding physician burnout. It continued at the November interim meeting of the AMA. We, a year and a half ago almost now, had the RAND study with the AMA that showed that physicians were spending 2 times as much time on the EHR as they were with patients, that the burnout level was going up, that physicians' career satisfaction was plummeting. We've seen some of this for years. I think, from my experience, I came into practice in 1990. I think in 95, 97, when they came out with the E&M guidelines, some of that coding documentation came from outside. It had nothing to do with how we really take care of patients or what was relevant to taking care of the patients. Physicians felt the pressure of that. Documentation got more and more copious. And then you get EHRs and you get note bloat and you get all the meaningless use, meaningful use requirements that tell us to tick some boxes that showed functionality of the EHR in terms of it had this code, this capability, this field was able to be populated, but it didn't do anything for the patient-physician interaction and for the quality of care we were delivering to patients. All of that builds up on the physicians. And so now we are seeing a critical mass. We're seeing that over 50% of physicians interviewed and surveyed are lamenting that they're losing their satisfaction, they're losing connectedness. Depression rates have gone up among physicians. They were high to begin with. I mean, it's always been a stressful, difficult role. It needed compartmentalization. Now we don't have time to compartmentalize. We are racing from patient to patient and still have the record waiting for us. And then we go home and we feed the kids, tuck them in, and spend another 2.5, 3 hours on the computer. And you hear this over and over again. The thing that kind of amazes me about HHS and ONC doing this listening session, you do these listening sessions when you really don't want to do something, or you're not ready or capable of doing something, right? Because they have all this information. I just mentioned 1.5 years ago we had it. I think that's one of the things that galls me about this. This was just placation and delay. If they really want to get something done, get to work on interoperability, reduce some of the cumbersomeness. They are at least talking to HHS, and I think they mentioned it. They're talking about reducing some of the MIPS requirements and easing some of that burden. But they've got to quit being in the physician-patient business as much as they are. I have a very good friend, Dr. Sean Jones, former president of the Kentucky Medical Association, who just published a book, Finding Heart in Art. It's about his journey of burnout. I think it's an incredibly brave thing for him to do. He's a prominent ears, nose, and throat physician in his community and prominent within the medical community at large. But it was a great gift on his part to other physicians. It's not every physician's journey, but the fact that he would take the time out of his life and his wife would allow him, she's also a physician, would allow him to expose himself this way, tells you how severe this is, how critical burnout for physicians is. And I think we as CIOs have an opportunity to help by really looking at the workflows and demanding of our vendors improved workflow.
Wow. So do you think there is I mean, is there a risk in speaking out against some of these things? I mean, is there a risk right now of talking about, certain technology? So if I were to sit here and say, Epic and Cerner, have created way too many clicks and way too much, or if I sit here and say Health and Human Services, ONC, macro MIPS, these things have put way too many burdens. Is there a blowback that happens to people that are speaking out about these kinds of things, or are we past that now where there's just so much of it going on that it's just a matter of getting to the right people to get the right things done?
Yeah, I think the risk is probably perceived to be there more by folks who don't have a clinical background. Those of us who have been practicing physicians, I think we're past worrying about the risk. We're desperate to find the right answer, and we feel that for the sake of our patients and for access to care, because when you burn out physicians, they resign their positions, they leave the practice, and access goes down. So if we're going to do that, I think we get over the fear. I think, and I know from conversations with the folks at Epic, I haven't talked to the folks at the other large EHRs, but with conversations with folks at Epic, and I watch at UGM and at some of the other conferences, folks are getting in their face. They're doing it in a civil way, which we always ought to do it in a civil way, but people are being very forthright about what the problems are, and they are starting to respond. And you're seeing some of that in the workflow changes. You're seeing some responsiveness. But I think they built, to your point, these very clicky systems that are incredibly complex coding. And to go back and correct that and to streamline workflows is a big lift. And I think it's just getting a critical mass of all of us saying, okay, no more. We're not going to tolerate this any longer. You've got to do better. And then I think they'll start moving. They also know, and I know, the barrier to change in IT, health IT, is huge, because the cost is so high to change. Tear-outs and re-implementations, I just went through one, they're expensive. And you do everything you can to not do it again. But I think if we're going to be good partners, and I always talk about good partnerships, our EHR providers And we as the users have got to have these hard conversations and be good partners and help each other to improve and get it right.
What is so we've talked a little bit about the IT side of it and the EMR providers. What needs to change on the regulatory side? That, I mean, we talked about, the MIPS burdens coming down, and maybe even some MU things have been eased. But are there some other things we can look at to maybe roll back, or some conversations we should be having that really drive forward, not just a listening session, but that we as health IT leaders, or maybe even a couple of the people at HIMSS that are listening to this, or Chime, that they could advocate for on Capitol Hill and really move things forward?
Yeah, I think HHS showed us a first step in eliminating the requirement for attending physicians in the academic centers to duplicate what's in the student note. They're starting to recognize that if it's in the record and it's available, it's in the record. It doesn't have to be duplicated. That's a great start. I think they need to look at the 95, 97 E&M coding guidelines, and I know they are, and say, is everything that we're demanding necessary in the world of an EHR, where so much of that social history, if I'm simply reviewing and moving on, I don't have to document it in every single note. You can follow my clicks. If you really want to audit me, it's auditable. But quit making physicians be scribes responsible for counting the number of boxes checked, and trust them that when they say it's a 99214 visit, it is. And if you want to trust and verify, because I believe, Reagan was right, trust and verify, then go ahead and look at the clicks periodically, do some random audits, but don't make people put all this cumbersome stuff into the note. It's time consuming. It fills up page after page. If you do a printout, it's just onerous to go through it. I think we can have those conversations. We can make those steps, but this first step by HHS to eliminate the redundant documentation for medical students, great first step. There's a lot more steps to be taken.
Absolutely. And we talked about that last week with Charles Boise on the show, just how much data is in those EHR logs that you could actually just retroactively go through and create a lot of that instead of putting the burden on a physician. And that's just probably one of many cases. The only other thing you and I talked about Augmetics last time, which is one of the ways to ease the burden. I saw that UPMC yesterday. I saw a post by Razu on what UPMC is doing with Microsoft in terms of having the machine do the notes and record the notes while they're in the room. So that was a partnership with UPMC and Microsoft. So hopefully more things will happen in that area. But as is always the case with you and I, we could talk for hours. It's time to close the show. So favorite social media posts of the week. I'll kick us off. So wow, I can't even read this. My eyes are getting so bad. I don't know what age that happens, but it's happened to me. So this is titled How You Treat Your Loyal Employees Determines Your Future. Oleg Vishin-Polsky, who I'm sure is an avid listener of the show, but he posted a cartoon. I love these cartoons. And it says, think twice before losing your best employee. And it has like a plank out over the cliff, and the employees walking the plank, except they're walking to land, while the executive who's losing their best employee is sitting out on the other end of the plank and about to fall into the abyss. And I think that's just a great reminder for us. So over to you. What do you have for us?
Yeah, I didn't go for a social media post. I went for something that was ringing in my ears this week, a comment by my dear friend Steve Heck. I don't know that he originated it, but he was the original person that I heard it from. Execution trumps innovation. And the reason I'm bringing that up is a lot of our friends are going to be at HIMSS and Chime, and particularly at HIMSS, there's lots of bright and shinies out there. We have all these opportunities to innovate. First rule, execute. Get it done right. I'd rather do old school right than new stuff wrong. And I think it pays off. You saw this in your work going to the cloud with your system. I saw it in the work of the team that I got to lead in the implementation of Epic. Execution means everything.
Yeah, so will you be at Chime or be at HIMSS?
I will not be able to. I had a family obligation, not going to be able to make it out.
Yeah, it's Well, I'm going to drive over there and look forward to catching up with some friends. So if you are a listener and you're going to be there, I would love to catch up with you. I'll be at the Chime event, the CIO forum on Monday, and then HIMSS the rest of the week. And still have some time slots if people want to get together. I'd love to catch up. So thank you again, David, for being on the show. That's all for now. Please, you can follow. Well, actually, I guess usually I say you can follow us. Do you have a Twitter handle? I don't know if you do.
I do not.
Oh, okay. Well, let's just say they can follow you on your articles you're writing for healthsystemcio.com, and my articles are over there as well. So great publication. Love those guys for the service they provide. You can follow me at the Patient CIO on Twitter. Don't forget to follow the show on Twitter, This Week in HIT, and check out our new website, This Week in Health IT. And don't forget, if you like the show, please take a few seconds and give us a review on iTunes or Google Play. And don't forget to come back every Friday for more news commentary from industry influencers. Next week, we will be doing our first live show with David Baker from Vegas. I have no idea where we're going to do it from. Probably not the showroom floor or the floor of the convention center, but we'll find somewhere to do it, and hopefully not the casino as well. I know David loves to play blackjack, so we will not be doing it from. I don't think you're allowed to anyway, but I could see him trying to push for that. So anyway, thanks again, David, for being on the show, and that's all for now. Look forward to talking to you next week.
Thanks, Bill. Appreciate it.